પ્લીઝ.
ગુડ આફ્ટરનૂન એવરીબડી. હમણાં રઈસભાઈએ બહુ જ સરસ જ બહુ જ સારી આપણી લાફ્ટર ક્લિનિક ચલાવી. એમાં એક વસ્તુ હું કહી શકું છું કે હસુભાઈને તો અમે બદલી નથી શકતા, પણ જલપાડીને ડેફિનેટલી જલપા બનાવી શકીએ છીએ.
હું છે ને આ સત્ય ઘટના છે. જલપાડી એકચ્યુઅલી આ રીતે જ મળેલી. હસુભાઈ કોઈ હતા નહીં, મને જ મળેલી. જલપાડીએ મને ફોન નંબર આપ્યો. હું કાપલી લઈને આવ્યો ઘરે અને મેં મારી વાઈફને આપી કે આ મારી 6ઠા 7મા ધોરણવાળી જલપાડી, અને એણે ફોન નંબર આપ્યો છે. તો મને એમ કે મેં બધી જ વાત કરી 120 કિલો આ તે બધું, તો એણે ફોન નંબર ફાડી નાખ્યો. મેં કહ્યું શું કામ ફાડી નાખ્યો, તું કેમ ઇનસિક્યોર? કે બેરિયાટ્રિક કરાવી દે તો.
Bariatric surgery has been there for a very long time, more than 70 years now. And in spite of that, we find that there is still a lot of controversy. People think that it isn't a boon and it's a bane. So what I'll do is I'll just go through a few case scenarios. But before we do that, I'll just like to talk about what's boon. Boon means that anything that is helpful, beneficial, improves your quality of life or is a blessing. And bane is something which is a distress which causes a continuous trouble or unhappiness. So based on these two definitions, we'll just go ahead and see. Now this was a 44-year-old lady who presented to us with diabetes over 23 years, all types of medications, resistant to insulin, and in spite of that her HbA1c remaining at 11.9. Hypertension for 15 years, all medications going on, and still an uncontrolled blood pressure. To make matters worse, she had undergone angioplasty, she had undergone a coronary artery aneurysm coiling, diabetic foot, polyneuritis. You name the complication of diabetes and she had it. Diabetic retinopathy with almost loss of vision in the left eye, right eye vision significantly reduced, and she was referred to a retinal surgeon who said that the diabetes and the blood pressure have to be controlled before taking her up for a surgery, and since medical management was not possible, she was referred to us. So we went ahead and did a loop DJ with a sleeve gastrectomy, which is a strong metabolic surgery for her, in which we do a sleeve gastrectomy and bypass simultaneously. Now, after a year, her weight had reduced to 57 kg, blood pressure was normal, her HbA1c had reduced to 6.1, no antihypertensives were required, oral antidiabetic, only one medication, and she was operated for retinal surgery and her vision improved. So whether we call this surgery a boon or bane for us is something which we ourselves need to decide. This is another case, and this is, you can see this huge ulcer. This patient had this huge ulcer for 17 years. He had met all plastic surgeons, vascular surgeons, and it wasn't getting better. And one of the major reasons was the weight, 175 kg, diabetic, hypertensive, hypothyroid. And his life was a misery. He couldn't live a normal life at all. Now, after we operated, that is him after 1.5 years, 3 months to 4 months down the line, his ulcer had healed, his weight reduced by 1.5 years to 102 kg, the diabetes and the blood pressure went off. And he has been able to live a fairly normal life after that. So again, I would ask you whether this surgery was a boon or bane for him. Now, all the cases we operate don't have a very smooth ride. Some of the patients are going to have a little bit of a rough ride. So I'll just show you a couple of cases where the ride was rough. Like this particular patient, she came from Australia. She had been struggling with obesity for more than a few years, 105 kg weight. We did a sleeve gastrectomy for her. Now she had a post-operative bleed and we had to go back in and do a diagnostic laparoscopy, evacuation of the clot. Less than 1% of the patients are going to have that. She comes back after a week of discharge and she has vomiting. We do a CT scan to find a leak and we have to place a stent. So 1% of the patients develop either of the two complications, and here I had one patient who had both the complications. She had an uneventful recovery after that and went home, and that is her before and after the surgery. Now, unfortunately, she was the niece of a very, very close friend of mine. And I met her again after a year and I asked her, "Kevu lage che tane? Do you feel happy?" So she said, "Sir, after the weight loss and my looks, I am more confident, I can manage my family better, and I am living a better quality of life." So yes, she had been, She had trouble for a very short time, but in the long term, when you see her, it was a boon for her. Similarly, another case, see, I'm talking about these complications to show you that there can be short-term problems, but in the long term, all these patients have a significant improvement of quality of life. This was another lady, we did a DJB sleeve, and she had a leak. We had to do a diagnostic laparoscopy, then go back in, do a gastric bypass, and she was fine after that. Now, she was struggling with her diabetes, pseudo-Cushing's, weight was 87, BMI 38, uncontrolled diabetes, and to make matters worse, she developed NASH. And that was the reason she came up for the surgery. Post-operatively, a year after the surgery, her weight had dropped to 62, HbA1c was 5.6, and the fatty liver had reversed. So again, she had problems after the surgery, but when you see in the long term, it was a bane to begin with, but ultimately a boon. Bariatric surgery has been there for more than 70 years, but there were three major milestones. The first was in 1966, when the gastric bypass was done for the first time. So that's going back more than 55 years. The second was in 1997, when the mini gastric bypass was started, and in 2002, when the sleeve gastrectomy was started. When I started bariatric surgery in 2005, we had only three options for the surgery: a Roux-en-Y gastric bypass, a BPD, or a gastric band. I never liked the gastric band, so I never did the gastric band. It was a very simple surgery. 2013 guidelines, the sleeve gastrectomy was also added to it. And presently, this is the gamut of bariatric surgeries which are available. So a huge number of surgical options are available, but three procedures remain the mainstay: the sleeve gastrectomy, the gastric bypass, and the one anastomosis gastric bypass or the mini gastric bypass. So when we look at the world trends, in 2008, about 3.5 lakh cases used to be done in the world. In 2018, there were about 7 lakh cases which were being performed. And sleeve has become, the green line which you see is the sleeve gastrectomy, which has become the commonest procedure, and the Roux-en-Y gastric bypass has reduced from the commonest to about 30% of the cases. And when we see the further trends, we find that sleeve gastrectomy remains the most common procedure over the years because of its low complication rates and fairly good results. So Roux-en-Y gastric bypass has its sets of advantages and its set of complications. The sleeve gastrectomy has its significant advantages, and the only major problem which I've seen, I've done more than 1,000 sleeves now, the only problem I've seen with it is a reflux disease problem, which most of the times can be managed by medications. And the mini gastric bypass, again, with fairly good results. Now, there have been 2 trials which have looked at patients over a long term. The sleeve plus trial, which is considered as one of the hallmark trials, which looked at patients for 10 years, sleeve versus a bypass. And at the end of that, they found that the weight loss is not significantly different. And when you look at the comorbidities, there is no statistically significant difference between the two. Only in hypertension, the gastric bypass over a 10-year follow-up scores more than the sleeve. Similarly, there is this Y-omega trial, which is a 5-year trial, which compares the mini gastric bypass, commonly called in India, also called as one anastomosis gastric bypass, to the RYGB. And here also we find that both of them at the end of 5 years are almost similar, except that in the mini gastric bypass, some patients will have reflux problem, which is less commonly seen in the gastric bypass. And about 8% of the patients of mini gastric bypass will require a conversion to a Roux-en-Y gastric bypass. So the question comes down to which of these surgeries are best. Almost all of them are equivalent over a 10-year follow-up. In a 10-year follow-up, it doesn't make any significant difference as to which one you perform. It's more or less based on discussion with the patient, what the patient preferences are, and the decision can be taken. Now, we always have been talking about diabetes, hypertension, weight loss. But are there other things where we find bariatric surgery to be beneficial? So this was a trial, the SWIFT trial, which looked at patients with osteoarthritis, and they found that a large number of patients, there was a significant symptom relief, and 20% of the patients did not require a knee replacement after the weight loss. The second issue we find is obesity-associated fertility issues. So when you look at the female problems associated with obesity, PCOS reduces from 45% to 7%, menstrual irregularities from 56 to 7%, and infertility from 18% to 4%. Now, one very important thing is we talk about treatment. The second thing is also talking about prevention of a disease. So when you have pre-diabetic patients, and if I don't operate them, over a 15-year follow-up, you find that 69% of obese patients pre-diabetic will get diabetes. Similarly, when they are operated, only 6.7% of these patients will become diabetic. So it's not only for treatment, it can be also very good for prevention. And here, the gastric bypass gives us better results than the sleeve. Now, NASH we have all been talking about for many years now, and it is nowadays called as MASLD. And obese patients have 85% prevalence, diabetic 30 to 75%, metabolic syndrome 50%. And the disease progresses in 20% of these patients to MASH, and 20% of MASH patients go to cirrhosis. So what happens when you operate on them? If patient has only steatosis, then it gets resolved in 63% and same in 27%. When there is steatohepatitis, it resolves in 90%. And patient, when they have fibrosis, you don't get a resolution, you would get just some improvement. Another aspect is cancer. We all know that obesity leads to higher incidence of cancer. When bariatric surgery is performed, the incidence of cancer reduces. So I've given all these examples, I've talked about the benefits. So the point comes as, is bariatric surgery boon or bane? So what is the truth of life? जिंदगी का सत्य क्या है? क्या कोई भी ऐसी चीज़ ज़िंदगी में होती है जो सिर्फ फ़ायदा दे? जो आप अपने मेडिसिन पेशेंट्स को देते हैं, क्या उसके साइड इफ़ेक्ट नहीं है? जब आप ऑपरेशंस करते हैं तो क्या उसके कॉम्प्लिकेशंस नहीं है? इसी तरह से ज़िंदगी में कोई ऐसी चीज़ नहीं होती जो सिर्फ आपको फ़ायदा देगी. हर चीज़ जो फ़ायदा देती है वो कहीं ना कहीं थोड़ा बहुत नुकसान देती है. और बेरियाट्रिक सर्जरी व्हाट वी फाइंड इज इट गिव्स लॉन्ग टर्म boon. There can be short term bane. The problems of obesity are these many. If the problems of surgery come, they can be very, very less. And most of them can be managed by medications or conservatively. Thank you very much.